Yeah, so nice to meet you all, and thank you so much from the organization committee for the invitation to bring me here to talk about the studies that we have conducted in Denmark. And as Eric mentioned, I'm a cardiologist, so I don't know a lot about infections and vaccines, but my professorship is within methods, and I'm a professor in pragmatic randomized controlled trials, and that's why vaccines are really unique to do these kind of studies in. This is my disclosures, and I think the main or the biggest disclosure is that the flu vaccine trials we have conducted, Dan-flu, Gal-flu, and Flunity, they are funded by Sanofi, and the Dan RSV trial that I'm also going to touch upon is funded by Pfizer. So, first of all, when measuring vaccine effectiveness in older adults, we can in general do it two ways, right? We can do the observational way or do the randomized controlled trial. Using observational data, then we're just using usual care, which vaccines participants have received or whether they have received vaccine, and then we follow them through the registries to look and compare outcomes. In a randomized controlled trial, there we of course prospectively randomize and in a randomized allocated fashion give different vaccines, and I'm going to touch upon why that is important. We know that looking at the level of evidence pyramid, that randomized controlled trials are on top. It's the only way we can do evidence where we at least are assessing causal association between vaccines and outcomes. But cohorts and observational data is also extremely important. On the far top of the evidence pyramid, we have meta-analysis of randomized controlled trials. It's not meta-analysis of observational data. It's meta-analysis of randomized controlled trials, and I think that's a very important part of this, because often you see a meta-analysis being published testing treatment effects of observational data, but if the effect estimates are wrong in the studies going in, then the summarized effect estimates will be even more wrong. So it's just important to underscore the meta-analysis are designed to combine randomized controlled trials and not designed to combine observation data when you are looking at treatment effects. And this is just one example, and it's because it's a Danish example, so I hopefully don't want to distress anyone else than my own countrymen. This is an observational data assessing in the Danish registries which kind of mortality events, statins, and I'm a cardiologist, but I guess most of you also know that statins is something that we prescribe to all of our cardiac patients because we know from randomized evidence that it lowers the effect or lowers the risk of cardiovascular events, right? We lower cholesterol and thereby lowering the risk of cardiovascular events. But these Danish authors published in New England Journal, as you can see, and this is an observational study using Danish registries in 2012, showed that statins apparently lower the risk of cancer mortality. But statins also increases the risk of cardiovascular mortality. It's very strange, right? That's something that we wouldn't really imagine. And they did it using two different methods of observation data. And again, this was published in New England Journal of Medicine. But isn't there reason for finding this kind of association? Yes. It's the reverse causality, right? People that we prescribe statins are people who are already cardiovascular ill, sick, and that's why they die of cardiovascular causes. Because they die of cardiovascular causes, they can't die of other things like cancer. So this is a completely wrong observational study assessing treatment effects, and that's my important note, that when assessing treatment effects, we can use observation data for a lot of amazing things, but treatments is probably not the best solution, right? And just to show, combining in a meta-analysis of all the randomized controlled trials conducted with statins, we of course see that statins lower the risk of any kind of cardiovascular mortality cause, And there is absolutely no effect on cancer mortality when combining randomized controlled trials. And that is also the reason that the Oxford group who conducted the recovery trial when the pandemic reached the world, and they saw a lot of observational data being published about which treatment should we give, horse medicine should we give, whatever, to these patients to lower the risk of outcomes. They said, hey, hold off, you can't use observational data to assess treatment effects. And they wrote this commentary in New England Journal, The Magic of Randomization versus the Myth of Real-World Evidence. And they write, and now I'm just quoting them, promotion of non-randomized analysis of databases as a rapid source of real-world evidence about the effects of treatments is a false solution to the problem caused by the bureaucratic burdens imposed on randomized controlled trials. And I know that everyone in here knows why randomized trials are important, but it's quite simple. It's when we randomize, the groups are comparable in all the baseline characteristics, event rates, whatever. The only thing that differs is the treatment that we have randomized them to, so 2 different vaccines, and that's the only way we can assess a causal effect between the treatment and the subsequent outcomes. So, moving into vaccines, and one of the first endeavors we embarked upon was, together with Sanofi, testing whether their high-dose flu vaccine significantly lowers the risk as compared to the standard-dose flu vaccine, which we at least use in my country for the seasonal vaccination program. Sanofi, they published in 2015 their trial where they showed that the high-dose flu vaccine significantly lowered the risk of influenza illness with 25%. But that was not powered or designed for clinical outcomes, right? It was purely whether you lower the risk of influenza incidence, influenza illness. At the point when we started embarking on designing a power trial to assess whether high-dose flu vaccine significantly lowers the risk of heart outcomes, combining all randomized evidence in a meta-analysis, we identified that 105,000 individuals worldwide had been randomized in randomized controlled trials to either receive a high dose or standard dose flu vaccine, assessing whether the high dose significantly lowered the risk of hospitalizations. We knew that we needed to recruit more than 300,000, right? So even combining all the randomized controlled trials at that time did not provide us with significant power to assess whether a high dose flu vaccine lowers the risk of hospitalization as compared to a standard dose. But luckily, we have a solution. In the Netherlands, like in Denmark, we have our nationwide registries. They are often used to assess observational treatment effects, which, as I mentioned, are often biased by confounding factors. And these 3 registries that I show here are not they are paramount for any kind of research question, but the list of registries that we have in Denmark and the Netherlands are almost unlimited, because the Danish free-for-all public healthcare system is reimbursed, right? So we need to know which services all Danish citizens get, so we can reimburse all the hospital and all the physicians. Besides the registries in Denmark, we also have an e-box system, and I think you guys have something quite similar, but it's linked to the Social Security number, where we send out priority emails. When I am calling in a patient for an outpatient visit in my heart failure clinic, that's through the e-box system, and all other communications from the government and through the e-box system. That's where I get my paycheck every month. If I need to go to a seasonal vaccine, or my son needs to get the children's vaccines, then it's also through the e-box system. And this is linked to the Social Security number. So we can identify people through the registries and invite them directly to participate in research. And the combination of this, the fact that we can identify all Danish citizens with a specific phenotype, regardless whether it's hypertension or diabetes or dementia, and invite them through the e-box system, it makes Denmark a quite unique place to do pragmatic randomized controlled trials. The first time we tested this system was the Danflu-1 pilot trial, so it was just a feasibility trial, where we tried to assess whether we could do a giga trial within the nationwide registries, living the best of two worlds, combining the real-world accumulated data from the real-world scenario with a prospective randomization, so we didn't need to rely on the observational data of which vaccines participants received. The unique thing when you do this randomizing within nationwide registries is also that you can compare your study population, Danflu-1 population, with everyone else in the country that could have participated in your trial, so you can really assess the generalizability of your trial results because you have data on everyone. You know, you have the same data on those that you randomize as those that you don't randomize, making it possible to assess the generalizability of your study results. Danflu-1 was such a success. We were allowed to use this system, and that's why we moved on together with Sanofi to design the Danflu-2 trial. The first trial in a general older population testing with a high-dose flu vaccine versus a standard-dose flu vaccine significantly lowers the risk of hospitalization events. So heart events, remember, that's not what our regular flu trials are powered for. It's powered for whether you can prevent a positive swab and symptoms. Here, it's heart outcomes, your hospitalization events, like all of our cardiovascular trials are designed for. As mentioned, we knew that we needed to recruit close to 340,000 individuals to do a trial that was sufficiently powered. So the Danflu-2 was a pragmatic, register-based, open-label, active-controlled, randomized controlled trial. We aimed to recruit 340,000. We only had inclusion criteria, and that's just, you know, those who are willing to or are liable for a free standard dose flu vaccine, 65 years or above, and then they had to be able to sign an informed consent. We didn't have any formal exclusion criteria. Participants were randomized in a one-to-one fashion to either high-dose flu vaccine or standard-dose flu vaccine, and then all follow-up were done through the nationwide registries, both for baseline characteristics and follow-up data. This is the actual how we did it. So we identified the 1 million Danish citizens 65 years and above, sent them an e-box invite to participate in the study during the annual flu vaccination season, invited them to a homepage where they saw a video of me giving the information needed to sign informed consent. And this trial is also, or the Danflu program, Danflu-1, is the first trial ever in the world where asynchronous informed consent has been approved. But otherwise, if you don't do this asynchronous, then you can't recruit 340,000. We don't have enough physicians or healthcare professionals to be able to talk with this many people to get informed consent. They signed the informed consent online after watching the video, and then they were guided towards the trial clinics, where they were then randomized in a one-to-one fashion to either receive the high dose or the standard dose flu vaccine. My group at Gentofte Hospital worked as the central trial site. The only data that we received was the social security number from the trial sites and what they were randomized to. That data was then subsequently uploaded to the nationwide registries, where all data on baseline and follow-up data were obtained. So participants were followed for clinical outcomes from 14 days following the vaccination until 31 of May the following year, and the primary outcome was hospitalizations for influenza or pneumonia. We also had secondary endpoints, which we also powered our analysis for, and I'm going to get into that in the results. So here you can see the flow diagram. Over the 3 seasons of recruitment, we randomized in total 332,000 Danish citizens to either receive a high-dose or standard-dose flu vaccine, and then followed them through the registries. Here you can see the baseline characteristics. The mean age was 74 years, and 49% were female, and 54% had at least one chronic condition. Here are the main results of the Danflu-2 trial. So we saw that hospitalization for influenza and pneumonia occurred in 1,138 participants in the high-dose group, and in 1,210 participants in the standard dose group, corresponding to a relative vaccine effectiveness of close to 6%, which didn't reach statistically significant difference. So because our primary outcome wasn't statistically significant, as you can see here, we were not allowed to test any of the secondary outcome in our hierarchical testing order. But as you can see, we found that the incidence of hospitalization for any respiratory hospitalization seemed lower in the high dose group versus the standard dose group, corresponding to a relative vaccine effectiveness of also close to 6%. Likewise, the incidence of hospitalization for influenza seemed lower in the standard dose or in the high dose group versus the standard dose group, corresponding to a relative vaccine effectiveness of close to 44%. Just as a comparison for this event, influenza-like illness in the phase 3 trial that Sanofi conducted, it was close to 25. So it seems as if there's a bigger effect on hospitalization for influenza than just having influenza with a high dose versus a standard dose flu vaccine. Again, not statistically significant for the primary outcome, so these results need to be regarded as hypothesis generating. We saw that there was consistent effect across all our pre-specified subgroups reported in the trial. And moving on to just one of the sub-analysis that we did, because when you do trials that are this large, even the subgroups are larger than the largest trial ever conducted within this theme. So looking at cardiologists, one of the first subgroups we looked at was those with cardiovascular disease at baseline. As you can see, we had more than 90,000 people who had a cardiovascular disease. And the largest trial ever conducted within cardiovascular medicine, testing high dose versus standard dose flu vaccine, was 4,000, right? So you can see, doing giga trials, even the subgroups are larger than the largest randomized control evidence existing. But as mentioned, we saw that the incidence of hospitalizations for cardiorespiratory seemed lower in the high dose group, corresponding to a relative vaccine effectiveness of 5.7. And we would imagine that this is due to the respiratory hospitalizations, right? It combines the cardiac hospitalization with the respiratory in a combined outcome. But as you can see here, it's actually due to the cardiovascular disease hospitalizations, corresponding to a relative vaccine effectiveness of 7.2%. That's quite interesting that it's the cardiovascular hospitalizations that we prevent when giving a high dose versus a standard dose flu vaccine. And looking even more in detail into the cardiovascular specific hospitalizations, it's heart failure hospitalization that seems to be prevented with a high dose flu vaccine versus a standard dose flu vaccine. The last subgroup, and we have done a lot of subgroups already in these, because again the subgroups are larger than the largest randomized evidence conducted before the DANFLU-2 trial, is pericarditis and myocarditis. And just again to show that just in DANFLU-2 we have close to 1,300 participants with a history of a previous myocarditis or pericarditis, which is a very, very large sample in a randomized controlled trial of vaccines. We wanted to assess whether the high dose flu vaccine significantly lowers the risk of pericarditis and myocarditis. And as you can see here, it seemed as if that the incidence of pericarditis or myocarditis was lower in those who were randomized to the high dose versus the standard dose flu vaccine, which is also the first randomized evidence, in such a scale assessing risk of pericarditis, myocarditis with a vaccine. And remember, this is a high dose vaccine versus a standard dose, where it seems as if we can prevent some of these cardiac events by providing better immunization. Besides the DANFLU-2 trial, we also implemented the DANFLU-2 protocol in Galicia, Spain, after recruiting 1 year in Denmark, which constituted the GALFLU trial. So the GALFLU trial was designed based on the DANFLU-2 protocol with the prior intention to pool with our DANFLU-2 trial population, increasing the statistical power and the external validity, and thereby increasing the generalizability, right? And it was also to test whether we could do these giga trials multinationally. And Galicia in Spain have exactly the same registries-wise why we could execute our protocol there, combining these two into one pooled analysis, the Fluency HD study, which constitute close to 500,000 individuals. As mentioned, it was just the same protocol, so we assessed the same outcomes. The only thing that changed was that laboratory-confirmed influenza hospitalization was upgraded to one of the key secondary outcomes, but otherwise it was the same outcomes as in DanFlu 2. Here you can see the baseline characteristics, and they were balanced between the two randomized arms. Looking at Flunity, combining DanFlu and GalFlu, we actually saw that the primary outcome of hospitalization for pneumonia influenza reached statistical significance corresponding to a relative vaccine effectiveness of close to 9%. Likewise, all the key secondary outcomes, and that's hospitalization for cardiorespiratory disease, hospitalization for laboratory-confirmed influenza, and all-cause hospitalization were all significantly lower in the high-dose group versus the standard dose group. The only one that didn't reach statistical significance, or where we didn't see an effect, was all-cause mortality, as you can see on the bottom. The effect was consistent across all our subgroups assessed. So just in summary, from the Flunity HD study, high-dose vaccine versus standard dose vaccine significantly lowered the risk of laboratory-confirmed influenza hospitalization corresponding to 52% relative risk reduction, also a 8.8% lower risk of hospitalization for pneumonia influenza, and a 6.3% lower risk of hospitalization for any cardiorespiratory disease, and lowered the risk of all-cause hospitalization with 2.2%. But these systems can be used for any kind of vaccine. That's why we also last year initiated the Dan RSV trial, testing the new RSV vaccine for the elderly, again designing a trial powered to assess whether the new RSV vaccine significantly lowers the risk of hospitalization events, not just whether it lowers the risk of RSV disease. And we plan to randomize 130,000 Danish citizens to either receive an RSV vaccine or no RSV vaccine. And the objective, again, was to assess whether the RSV vaccine significantly lowers the risk of hospitalization events amongst the 60-plus-year-old. The Dan RSV trial was a pragmatic, register-based, open-label, randomized controlled trial conducted last season. And as mentioned, we plan to randomize 130,000. Again, we didn't really have no exclusion criteria. The only inclusion criteria was that you were 60 years or above, and people gave informed consent online, and were randomized online as well, and it was only those who were randomized to the RSV vaccine that had to show up for the vaccine visit, as I'm going to show you later. The control group could just stay at home. We used the same setup, identified Danish citizens 60 years and above, that's 1.4 million, invited them through the e-box system, guided them towards a video of me. Now the video is a little more professional, and I became a little elder, more old in the time span. But the same method, then we randomized people online to either stay at home or to actually show up for the RSV vaccine, because here in this trial we didn't have a vaccine comparator. Participants were followed for clinical outcomes from 40 days after the initial booked vaccine visit, and the primary outcome was hospitalization for RSV-related respiratory tract disease. We also had key secondary outcomes that we were allowed to test for statistical significance if the primary outcome was significant in this hierarchical pre-specified order. As you can see, we invited 1.4 million, and we ended up randomizing more than the aim of 150 or 31,000 Danish citizens to either receive an RSV vaccine or not to receive a vaccine. Here you can see the baseline characteristics. They were well balanced. The age group was slightly younger than in the Dan RSV trial due to the inclusion criteria only 60 years and above. And moving on to the primary outcome, hospitalization for RSV-related respiratory tract disease, which occurred in 18 people in the control arm and 3 people in the RSV arm, corresponding to a relative vaccine effectiveness of 83%. Because the primary outcome was significant, we were allowed to test our key secondary outcomes. And as you can see, the RSV vaccine also significantly lowered the risk of RSV-related lower respiratory tract disease, corresponding to a vaccine effectiveness of close to 92%. It lowered the risk of hospitalization for any respiratory tract disease, corresponding to a vaccine effectiveness of 15.2%. We also saw lower incidences of RSV-related hospitalization for RSV-related cardiorespiratory disease, and hospitalization for any cardiorespiratory disease, and also hospitalization for any lower respiratory tract disease. The treatment effect was consistent across all our pre-specified subgroups, and the safety events also seemed to happen in similar frequency in the two groups. So what could we conclude from the Dan-RSV trial? We concluded that in this large-scale innovative phase 4 trial, the RSV vaccine reduced the incidence of RSV-related respiratory tract disease hospitalization, RSV-related lower respiratory tract disease hospitalization, and hospitalizations for any respiratory disease among adults 60 years and above. Moreover, the RSV vaccine was associated with a reduction in hospitalizations for any cardiorespiratory disease, suggesting a potential downstream cardiorespiratory benefit of RSV immunization. As you might remember, we saw that for the DanFlu2 trial, that it was especially the cardiac hospitalizations that the high dose significantly reduced as compared to the standard dose. We also saw in the Dan-RSV trial that we lowered the risk of any cardiorespiratory disease. So we were very curious, is it the same? Is it really the cardiovascular hospitalizations that we prevent also with an RSV vaccine? So we conducted a sub-analysis looking specifically at this question. And as you can see there, we saw the opposite. We saw that it was the respiratory tract disease hospitalizations that an RSV vaccine significantly lowered, which also makes sense, and not the cardiovascular hospitalizations. So, in summary, randomized controlled trials are the optimal study design to understand the causal relationship between an intervention and outcome when assessing treatment effects. Randomized controlled trials should be and are evolving to become less bureaucratic, less expensive, and more generalizable by being embedded within real-world settings, so combining the best of two worlds. Not relying on observational data when assessing treatment effects is extremely important. Randomized real-world studies can harness the power of real-world data while preserving the ability of randomization to ensure that the true effect of an intervention can be assessed. In the absence of randomization, analysis of most observational data from the real world, regardless of their sophistication, can normally only be viewed as hypothesis generating, and they cannot establish causal relationship between the intervention and the outcome. And I think that's the most important part of this, that we at least have done an effort to try to push what is possible when leveraging these real-world data sources, real-world evidence, not just relying on analysis of retrospective gathered data within our societies, because those who get a treatment is very different from those who don't get a treatment. And that is especially true for vaccines. In Denmark, SSI, they do these vaccine effectiveness estimates of all the vaccines seasonally. They are extremely biased. We see that the vaccines lower any kind of event, but those who get vaccinated versus those who don't get vaccinated are very different. They are much more health-seeking than those who don't get vaccinated. So if we don't try to leverage these sources and embed randomization all over when we assess treatment effects, and that doesn't matter whether it's vaccines or statins, as I showed you before, then we can't really rely on our effect estimates when testing treatment effects. So I showed some cases of how we hopefully can do it for the future, and hopefully we can also expand these methods to also be used in the Netherlands. Thank you so much for the attention.